Welcome to AETCM, the Emergency Medicine Channel. Today I am presenting Rapid Sequence Intubation. I am Dr. Cecil Mariajos. Rapid Sequence Intubation is nearly simultaneous administration of induction agent and NMPA after a period of pre-oxygenation and cardiopulmonary optimization for tracheal intubation. There are 7 T's for rapid sequence intubation: preparation, pre-oxygenation, pre-intubation optimization, analysis with induction agents, positioning, placement of the tube, post-intubation management. Coming to preparation. In the initial phase, the patient is assessed for intubation difficulty and abnormal physiology unless this has already been done, and the intubation is planned, including determining the dosages and sequence of drugs, tube size, and laryngoscope type, blade, and size. Drugs are drawn up and labeled. All necessary equipments are assembled, which include oxygen source and tubing, ambu bag, mask with valve, various sizes and shapes, oropharyngeal airways of small, medium, large size, nasopharyngeal airways of small, medium, large size, suction catheters, yonkers, tracheal suction catheters, nasogastric suction connection tubing for particulate and large amounts of vomiters, suction source, pulse oximetry and cardiac monitors, carbon dioxide detector, endotracheal tubes of various sizes, laryngoscope blade and handles, syringes, Magel forceps, stillets assorted, tongue blade, incubating stillet or gum elastic bougie, water soluble lubricator anesthetic jelly, rescue devices like video laryngoscopes, laryngeal mask airway, intubating laryngeal mask airway, eye gel, surgical cricothyroidotomy kit, medications for topical airway anesthesia, sedation, and rapid sequence intubation. Coming to pre-oxygenation. It is a denitrogenation of lung alveoli and formation of oxygen-rich reservoir within lung FRC. Make the patient breathe for 3 minutes at normal tidal volumes, 100% oxygen at 15 liter per minute flow through a NRBM. When performed effectively, patient may have as much as 6 to 8 minutes of safe apnea before oxygen saturation falls to less than 90%. If saturation remains less than 93% or less, despite efforts, shift to BiPAP to increase the alveolar recruitment, reduce shunting, and increase EtCO2. Pre-intubation optimization. It is to improve the abnormal hemodynamic parameters prior intubation. Isotonic fluids, blood products, and pressure agents can be used. Coming to paralysis, it includes pre-treatment agents, induction agents, and paralytic agents. Pre-treatment agents are used to reduce the sympathetic responses to laryngoscopy and intubation. There may be tachycardia, rise in BP and ICP during the procedure. Laryngeal stimulation may cause laryngeal spasm, cough, and bronchospasm. We are using mainly 2 agents, that is lidocaine and fentanyl. Lidocaine, the dose is 1.5 milligram per kilogram, IV or topically. Indications are raised ICP, bronchospasm, and asthma. Even though we are using an elevated ICP, the effectiveness is not known. Coming to fentanyl, the dose is 3 microgram per kilogram IV. Indications are elevated ICP, cardiac ischemia, aortic dissection. Precautions: respiratory depression, hypotension, and chest wall rigidity. Coming to induction agents. Induction agents are etomidate, propofol, and ketamine. Etomidate, the dose is 0.3 to 0.5 milligram per kilogram IV, which have an onset of less than 1 minute and duration of about 10 to 20 minutes. The benefits are it decreases the ICP and IOP and neutral effects on BP. Caveats are myoclonic jerks, seizures, and vomiting in awake patients. There is no analgesia and it reduces the cortisol. Coming to propofol, the dose is 0.5 to 1.5 milligram per kilogram IV. And the onset of action is within 20 to 40 seconds and duration is 8 to 15 minutes. Benefits are antiemetics, anticonvulsant, and it also reduces the ICP. It may cause apnea and reduce the BP, and there is no analgesic effect. Coming to ketamine, the dose is 1 to 2 milligram per kilogram IV. The onset is within 1 minute and duration is about 10 to 20 minutes. The benefits are bronchodilation, dissociative amnesia, and analgesia. It can increase in secretion, increase in BP, and it causes emergence phenomena. Paralytic agents are three, mainly rocuronium, vicuronium, and succinylcholine. Rocuronium, the dose is 1 milligram per kilogram, and onset is 1 to 3 minutes, and duration of action is 30 to 45 minutes, and it causes tachycardia, longer duration of action and onset compared to succinylcholine. Coming to vicuronium, the dose is 0.08 to 0.15 milligram per kilogram, and 0.15 to 0.028 milligram per kilogram, which is a high dose protocol. The onset of action is within 2 to 4 minutes, and duration is 25 to 40 minutes in usual dose, and in high dose protocol it is 60 to 120 minutes. It may cause prolonged recovery time in obese or elderly, or if there is a hepatorenal dysfunction. Coming to succinylcholine, the dose is 1.5 milligram per kilogram, and onset of action is 45 to 60 seconds, and duration is 5 to 9 minutes, and it provides optimal conditions most rapidly. Complications of succinylcholine are fasciculations, transient increased intragastric, intraocular, and intracranial pressure, bradycardia, mesataspasm, malignant hyperthermia, prolonged apnea with pseudocholinesterase deficiency or myasthenia gravis. Contraindications for succinylcholine are pre-existing hyperkalemia, burns which is more than 5 days old, denervation injuries which is more than 5 days old, significant crush injuries, and severe infections if more than 5 days old, and pre-existing myopathies. Coming to positioning, sniffing position with a cervical spine extension and head elevation is to be done. This is sniffing position. There is a flexion of cervical spine and extension of atlanto-occipital joint. Height should be adjusted up to the navel of the operator. Select manner, application of firm backward pressure over the cricoid cartilage with goal of obstructing cervical esophagus, and it reduces the risk of aspiration. Coming to placement of tube. Approximately 45 to 60 seconds after administration of NMBA, it is relaxed, the body will be relaxed sufficiently. Place the ET tube during the glottic visualization with laryngoscope. Confirm the placement by 5-point auscultation and ETCO2. Post-intubation management. It is mandated to obtain a chest X-ray and confirm the position. Use opioid analgesic and sedatives to facilitate mechanical ventilation. Benzodiazepines, for example, midazolam, 0.1 to 0.2 milligram per kilogram IV, and opioids like fentanyl, 0.5 to 1 microgram per kilogram IV, or morphine, 0.2 to 0.3 milligram per kilogram IV can be used. Propofol infusion 0.05 to 0.1 milligram per kilogram per minute IV with supplemental analgesia. If there is no hypotension or ongoing bleeding, we can use that. Coming to supraglottic airways, these are devices placed in oropharynx allowing for oxygenation and ventilation without visualized or surgical insertion of a tube into the trachea. These are often a bridge to endotracheal intubation or a rescue device after unsuccessful intubation efforts. These are most often placed in apneic, unconscious patients. Their large cuffs can cause gagging and discomfort in awake patients. There are 4 types mainly. One is IGEL, second is King laryngeal tube, third is laryngeal mask airway, and fourth is Shilley esophageal tracheal airway. This is the IGEL. It has a soft gel-like cuff that seals perilaryngeal structures without inflation. The technique for insertion: lubricate the gel-like cuff prior to insertion and then advance the device into posterior pharynx until resistance is met and lips align with the lip line on the IGEL. Coming to King laryngeal tube. As seen in the figure, There are two cuffs, a distal cuff and a proximal cuff. Distal cuff, it inflates in the esophagus, isolates the laryngopharynx from the esophagus. And the proximal cuff, it inflates at the base of the tongue, isolates the laryngopharynx from the oropharynx and nasopharynx. King laryngeal tubes are single lumen tube with a proximal cuff that seals posterior oropharynx, while a distal cuff occludes the esophagus. It is placed blindly into oropharynx until the lip aligns to the device lip line. Balloon is then inflated to a pressure of 60 centimeters of water. After placement, slightly withdraw tube to allow it to fully occlude oropharynx. Complications are the tongue engorgement. This is a laryngeal mask airway. It consists of a single cuff inflated with 20 to 30 ml of air. Technique: place a gloved index finger into the oropharynx to guide the device into the oropharynx and position the cuff around the larynx. It is useful when vocal cords are not visualized. Intubating LMA allow an EDT to be passed through the lumen. Complications are partial or complete airway obstruction and aspiration of gastric contents. This is a Shilley esophageal tracheal airway. As we see, it is a double lumen tube, proximal low pressure cuff that seals pharyngeal area and a distal cuff that seals esophagus are present. After placing, proximal balloon is inflated with 80 ml of air while distal balloon is inflated with 10 ml of air. To determine the location of the device, first ventilate through the longer blue port. This allows the oxygen to be delivered through fenestrations between proximal and distal balloon. If chest rise is absent, endotracheal tube cuff is in trachea. Switch to ventilation through shorter, clear or wide port. This is the end of my presentation. Thank you.